Okay, our next topic is going to be third trimester bleeding or late trimester bleeding. And the way we're going to figure this out, the way we're going to approach this is by categorizing it into either painless or painful bleeding. And basically, if a patient comes in with late or third trimester bleeding and it's painless, I want you to think of either placenta previa or vasa previa. Now, placenta previa is going to be defined as vaginal bleeding that ceases spontaneously with or without uterine contractions. A lot of times the case history is going to include a history of trauma, coitus, or a recent pelvic exam right before the bleeding is starting. Risk factors include prior C-section, multiple gestation, multiparity, as well as advanced age, and a prior placenta previa. You're going to diagnose this by ultrasound. And basically, we're going to manage this based on the maternal stability. Now, the one thing you want to remember in the management of placenta previa is that you do no cervical exams. Pelvic exams are contraindicated. So basically, what you're going to do is you're going to see, is the mother stable or not? Now, if the mother or the fetus is in jeopardy, if there's maternal or fetal jeopardy, you're going to do an emergency C-section. And this makes logical sense. If there's fetal or maternal jeopardy, you're going to do an emergency C-section. If the lower placental edge is greater than 2 centimeters from the internal cervical os, you're going to do vaginal delivery. And if the mother is stable and it's after fetal lung maturity, and we know fetal lung maturity is when? It's at the 36th week, right? So if the mother is stable and it's after fetal lung maturity, this is when we're going to do a scheduled C-section, and we're going to monitor the mom and the fetus closely. And we know when placenta previa is actually when the placenta is implanted in the lower uterine segment, and it usually occurs over a previous uterine scar because the villi is actually going to invade into the deeper layers of the deciduobasalis. And what we want to remember for this, most importantly, is that there's no fetal distress. So what are you going to do if a woman comes in with third trimester bleeding? You're going to see if it's painful or painless. And if it's painless and there's no fetal distress, you're going to do an ultrasound, and you're going to see is there a maternal or fetal jeopardy. If there is, you're going to do an emergency C-section because there's jeopardy. If the mother's stable and there's fetal lung maturity, you're going to schedule a C-section. And only if you meet this criteria of the lower placental edge being over 2 centimeters from the internal cervical os can you do vaginal delivery. Now, vasa previa, same thing, third trimester or late trimester bleeding. It's going to be painless. But vasa previa, on the other hand, there is going to be fetal heart changes. So here where we said there's no fetal heart distress, vasa previa is going to have fetal heart rate changes. That's going to be progression from tachycardia to bradycardia to sinusoidal pattern. Now, vasa previa is actually life-threatening for the fetus, okay? Fetal exannuation and death occur rapidly. And the classic triad is going to be rupture of membranes, painless vaginal bleeding, as well as fetal bradycardia. And always your first step is going to be emergency C-section. So it's kind of easy. You have a third trimester bleeding. First you want to see is it painless or painful. Once you figure out it's painless, you want to see if the fetus is in distress. If there's no fetal distress, you're thinking placenta previa, and you're going to manage accordingly. And if there is fetal distress, you're going to go right to emergency C-section. Now, in third trimester bleeding, you can have painful bleeding as well. And if it's painful bleeding, it's usually not going to be these two. It's going to be either abruptoplacenta or uterine rupture. Abruptoplacenta is the patient's going to present with dark red vaginal bleeding that's associated with painful uterine contractions. This is usually going to occur around 30 weeks. And basically, in abrupto, it's going to be a sudden onset of vaginal bleeding, and there's going to be severe, constant pelvic pain, okay? And a lot of times, it's going to be in the setting of hypertension or trauma. A lot of times, it may be in the setting of a motor vehicle accident. But the main thing you want to remember is that it's a sudden onset, and it's going to be painful bleeding, and it's going to be associated with painful uterine contractions. Now, our first step here in abruptoplacenta is going to be the insertion of a large bore IV as well as a Foley catheter. Once again, we're going to manage these patients based on the stability. If the patient is stable, we're going to do tocolysis with magnesium sulfate, And we have to remember Retordin is contraindicated in pregnancy. If the bleeding is heavy, but the bleeding is controlled, or the pregnancy is over 36 weeks, we're going to do vaginal delivery. And if the patient is unstable, we're going to do emergency C-section, just like we did in the placenta previa. And if there was maternal jeopardy, we're going to do emergency C-section. Same thing over here. If the patient's unstable, we're going to do emergency C-section. In VASA, it's always unstable, so you're going straight to emergency C-section. So abrupto placenta, you're going to think of in the setting of hypertension or trauma. It's going to be dark red vaginal bleeding, painful uterine contractions. You're going to insert a large bore IV. Patient stable, tocolysis with magnesium. If it's heavy but controlled or the pregnancy is over 36 weeks, vaginal delivery. And if the patient's unstable, emergency C-section. And finally, we're going to go over uterine rupture. Uterine rupture, same thing. Third trimester, late trimester bleeding, but it's painful. And basically this patient's going to come in, you're going to look at the history, and they're going to come in with a history of a uterine scar. Excessive oxytocin administration is a common history they're going to come in with. And these patients are going to come in with a sudden onset of abdominal pain and vaginal bleeding, lost with electronic fetal heart rate, uterine contractions, and recession of the fetal head. Our risk factors are going to be our classic uterine incision, like we just talked about, a previous myomectomy, as well as excessive oxytocin stimulation. Now, we're going to treat these patients by surgery, okay? But basically, if the patient is stable and they're a young woman, we're going to do a uterine repair. Or if the patient is unstable, we're going to do a hysterectomy. Another time we're going to do hysterectomy is if the patient does not want further pregnancy. If she doesn't desire further pregnancy and they're stable, we can also do a hysterectomy. So we're going to do uterine repair in stable patients, or stable patients that don't desire future pregnancy. We can also do a hysterectomy, but if they're unstable, we must do a hysterectomy. So basically, when you get third trimester bleeding, you're going to see, is it painless or is it painful? If it's painless, you're going to see, is the fetus in distress? If the fetus is in distress, it's going to be vasa previa. You're going to do emergency C-section. If there's no fetal distress, you're going to diagnose placenta previa. You're never going to do a pelvic exam. If there is maternal or fetal jeopardy, emergency C-section. If the mother's stable, we're going to schedule a C-section. And if the lower placental edge is over 2 centimeters from the internal cervical os, we're going to do vaginal delivery. If it's painful bleeding and we have a setting of hypertension or trauma, and it's dark red bleeding associated with painful contractions, we're going to first insert a large bore IV and Foley. If the patient is stable, we're going to tocolyze them with magnesium and know that Retordin is contraindicated. If they're unstable, emergency C-section. And if the bleeding is heavy but controlled, or the pregnancy is over 36 weeks, vaginal delivery. And in uterine rupture, we're always going to do surgery. And if it's stable, we're going to do uterine repair. And if it's unstable, we're going to do hysterectomy. And this is everything you need to know on third trimester bleeding, which is super important for your exam, so make sure you know it.